Okay, I'd like to call the Board of Health meeting together on August 18th, 7:30. Rachel is gone. She's the chairman and the vice chairman helping out Ralph Harrison. So next would be roll call. Let's see, go by first name for me, but Toby's here. I see that Eric's here. Jeff's here, Lois is here, and Karen's here. So we're missing just Rachel and Josh, right?
Well, Doctor's online.
Oh, that's right. Okay.
Josh is on, but
Okay.
we don't have any voting on it this morning, so it doesn't really matter.
Okay.
And then Paula McNeil,
Yeah.
has essentially resigned from the board.
I'm sorry, who's resigned?
Paula McNeil,
Oh,
one of our citizen members that hasn't been able to join for a while. She's from the University of Wisconsin-Oshkosh. And scheduling just does not work for her to attend any longer. And with the, potential changes in committee structure that are coming up, just kind of held on making, any recommendations for new appointments until we know the outcome of that.
so we have a forum?
Yeah.
So you're right. Okay, need approval for the minutes? Move to be approved as presented. Second,
Second.
all in favor? Aye. Opposed?
Aye.
Oh, there you go. Public comment period, right? Is there anybody here that would like to speak? Anyone else here? I have time to get anyone else
Yeah.
here? Every time,
And then check Zoom.
and how about online? Is there anybody online, Zoom? Anybody on Zoom? Last call, okay. I want to answer the others, right? Okay, do it fine.
Go ahead,
No, I'm just ready to get.
The minutes, I didn't bring a copy of the agenda.
Okay.
No, thanks.
Up there, yeah, okay.
So, yeah, so minutes are done.
Never forgot that we approved that.
Yeah, so if you'd like me to start on business, but pretty short agenda today. Mostly just gonna give you updates on where things are at. It'll allow some additional time for discussion if you'd like. Want to apologize for the confusion on the agenda. We tried to move to Teams. Thought we had everything worked out with our county clerk's office for migrating to Teams, because we're starting to phase away from Zoom and onto Teams since our IT department has moved us out of Microsoft 365. We were gonna be the very first to do Teams as a board meeting and heard from them after we had scheduled that maybe we weren't quite ready yet as a county to do that. So we'll attempt it next time. But thanks, and again, apologies for the confusion there. On agenda item A, director of staff updates. I'll start with just a few general announcements and have supervisors fill in, and I'll come back around at the end. Big things that are occurring in the department right now. You have heard about some of these in our past meetings. Certainly our community health assessment is getting near a final draft form, and that community health assessment again is a compilation of data that is community specific, timely, and helps inform us about what the current conditions are in our community. Really a snapshot in time of conditions in our communities that impact health. And we know that health goes far, far beyond having medical care access and seeing a physician. The conditions in the community that are related to employment and education and housing and safety, access to childcare, all of those things are important in the community. And so you'll see a variety of measures in that and some interpretation of that data just to help you understand where we're at as a community. That will be completed yet this year. And then we'll be working on a community health improvement plan, and that community health assessment, all of that data, that helps inform the community health improvement plan, where we will further engage the community and stakeholders into identifying what are our best opportunities to make improvement, and those improvements cut across our entire community, from public health and healthcare to business to government as a whole, to all the different sectors of our community. And we will attempt to engage those sectors as much as possible in coming up with those recommendations, and then publish a document that will help inform the community about, hey, if I'm, if this is what my role in the community is, these are the things that I can do to help make our community a better place. And so more information to come on that. That is also going to be running concurrently with a new initiative or newer initiative where the Tri-County, Outagamie, Winnebago, and Calumet counties, all 5 health departments, and the 4 primary healthcare systems will be working together on a new community health assessment. So rather than having one that's just Winnebago County specific, we are going to be working with those partners across the 3 counties to essentially start a new cycle of working together on the community health assessment and community health improvement plan, such that we have more shared goals and more shared priorities, and hopefully we can make more of an impact by aligning our efforts and being a unified voice across healthcare and public health to make changes within our community. So we'll just keep you informed along the way, but wanted to let you know that a significant amount of time and effort goes into that, engages many partners, and we'll have more to follow up with. The other large project that's really going on within the health department outside of our regular duties is a foundational public health services assessment. And in past meetings, we've shown you what the foundational public health services are, provided some documentation on that. And we're in the midst of assessing ourselves against what those foundational public health services are. So doing an honest reality check about what it is that we can and cannot do with those foundational public health services. Where are we at? What are our gaps? Where do we feel like we're proficient? Where do we need more training? And what are some areas for us to focus on? This is also a statewide assessment. Every local health department within the county, or excuse me, within the state, ideally is conducting this assessment. The results of which will be compiled by a consultant, Reed Group, that's been hired out of the state of Washington, that has done these assessments for other states. And so in conjunction with our Wisconsin Association of Local Health Departments and Boards, we're conducting this assessment, and it'll inform us locally and inform us at the state level. That will provide information for the state in terms of what are the primary gaps, what are the differences between, more suburban and urban or larger health departments and smaller health departments. What are the differences in those foundational public health services, based on, being rural or the combination of services, what's working, and will help direct those future investments. So happy to discuss any more about those things that you might have, and we're happy to share the results of those assessments as we have them. Julia is in her division that this work right now is grounded for both the community health assessment and the foundational public health services assessment. Is there anything that you wanted to add to that?
No, just that our staff has been working very, very hard to complete this assessment that is very robust and has taken quite a few hours already to fulfill, but to complete. And kudos to Bev, our accounting associate, who's done a lot of work, and kudos to all the supervisors too, who have spent a lot of hours on this, but I think it's going to be very, very good. Thanks.
Question. Great work. What might our role be in either of those? We have to review, approve, is there any?
Yeah, so
work we need to do?
we'll continue to engage the Board of Health with questions, with, hearing from you about, where, and we need you as our community voice to let us know where you feel like, where are some of the gaps in our work? Where are some areas that you feel that we should be doing more work? Where should we let off the gas, like you did a few months back with, some of our ordinance changes? That's all informative when we have these documents in a final draft for you to review, certainly love to hear your feedback on those. Let us know if there's something that we missed that you'd want to see, that you have a question about, that helps you be more of an advocate for public health, at the county board level or at the community level. But we will engage you.
And one of the questions on that, just with, and again, I hate to talk about it, but we get the pandemic, and as the pandemic is ended, all these different statements and rumors and things were not true, are true, back and forth. So, as a community health, what I'm concerned about is, how do we get over that hump? So many people saying that was true, that wasn't true. And how are we, again, we only as a community only do what it comes down from the health department or the health board or the CDC. And some of it comes across now, it's not exactly true. They could have done certain things. It could help more people. So now, and you had the same thing too when you talked about the shots. People stopped in the 65 because they weren't sure anymore. So in that report of that, how do we do in the community to get that? It's not trust, it's more belief in that maybe the story's right, or how to get everybody back on the same page. We're all working together, not against each other, or stuff like that's not true, but that mind is true, things like that, because you can feel it in the community. People are talking about it, and now as part of it is what do we do in that report to help get that confidence back to that we're listening more now rather than picking a side kind of thing. So I think.
Well, Ralph, I think locally, we've learned a lot of lessons. I think we're waiting yet to hear, at a state and national level for really after action reports on what worked and what didn't, what we can do to be better prepared for next time. I think there's a lot of work going on with that right now that we haven't heard the results from. Fortunately, we're going to be hearing more about COVID. We're already starting to hear more about COVID again right now as cases increase. We've had a pretty significant increase in COVID activity occurring. It's still at a level far lower than at our peaks in the past, but nonetheless, it's still a significant increase that will likely continue. Hospitalizations are up. There's still a fraction of what they were, and so we will be having. It would be great to have, more of an understanding. I don't know if we'll actually get there with the public in terms of, what worked, what didn't work, and moving forward together. I think there's still a lot of mixed feelings, emotions, opinions about how the pandemic was handled. Our messaging moving forward, will be to focus on those that are most vulnerable. Certainly we'll have a new vaccine out this fall, which has already been chosen. We know that will be available. That won't be much of a public health sort of initiative as it will be a healthcare initiative. Vaccinations will be given primarily by healthcare providers. We will give vaccines to those that qualify for Medicaid. We will likely seek out opportunities to vaccinate groups that are less likely to become vaccinated and highly vulnerable. But it won't be anything like the efforts that we saw over the past couple of years. I wish I had a better answer right now for you. I agree that we have not come to consensus, as a community, as a state, as a nation on what worked, what didn't, what we accept, what we don't. I think that's going to take many years to occur. And I think we need to apply what we've learned so far in our communications and what we've heard back from the community in, making sure that we're doing the best we can to provide, really solid, and I really feel like we've always tried to provide the best communication and best evidence that we could. We've learned even more now, in these past couple of years to really help identify who benefits the most from vaccination, And we also have new opportunities for vaccination that this is going to have an impact on. For instance, and we have RSV vaccine that we never had before. I mean, that can prevent thousands and thousands of deaths in infants, can prevent thousands and thousands of hospitalizations in seniors that are more susceptible. We obviously have the flu season, which was partially absent, during the pandemic. So, I mean, so this fall will really be interesting in that we're having, not only COVID vaccine, a new flu vaccine, or updated flu vaccine, which, protects against 4 different strains of the flu, which is fantastic, and an RSV vaccine. So you're gonna be hearing more about vaccine. We hope that we can conduct messaging in a way that, that people that need that vaccine actually get it. And that, there isn't still some backlash about, the needs for vaccines or not. The benefits are there, and we hope that we can convince those that perhaps, maybe didn't believe in vaccines or felt like this last vaccine came out too fast, or had other, concerns about vaccination, that they'll take advantage of it if they're a hybrid group. So,
Glad you brought that up too. That's the last question. There was last 3 board meetings, there was one supervisor that always brings up the point. The pandemic's over. Why are we doing shots all the time? Right? We've heard that 2 or 3 times where he's asked that. So glad you explained it right there why we're doing it. Because he said, why are we doing it? It's over with. We shouldn't be doing it anymore. Who's paying for that? That kind of stuff. I heard that.
vaccination rates are down across the board, even for young children. Our primary objective in funding that we receive from the state is to ensure that children that are 2 years old are up to date on vaccine.
Are you talking about childhood?
Right now, I am.
Yeah, so it's not COVID vaccine.
No, I'm just saying across the board, vaccinations are down. As a health department, one of, our priority with our immunization funding is to help assure that children's at age 2 are up to date on their vaccinations. We've seen a decline there as well, because attitudes have shifted in general. People are questioning, have questioned more, the role of vaccine, the risks of vaccine. There's been, much information put out there that, perhaps hasn't been validated. We have an extraordinary track record with vaccines, and we do hope to make progress with the community to trust that vaccines are protective. And some have changed their minds, and they do feel that vaccines are harmful rather than helpful. And I think there's a lot of evidence to the contrary that they're very, very helpful. And
Do doctors address this when they bring their kids in for their well baby appointments? and
yeah,
stuff?
and part of one of the gaps that we have from the pandemic was there were less visits to doctors. People stayed away from healthcare. And as we encourage and identify those that are not up to date, we hope there'll be some meaningful conversations that will help move that along. Jackie, if there's anything else you want to add, any of this?
It is just put physicians too in difficult places when you have a patient, client, parent that are very resistant. If a doctor can offer and they speak about it. But if you push too hard, then the patient and their child are not going to return, and then they won't have health care at all. So they do talk about it. It is always brought up. That is part of their duty and their due diligence. But they know that, they offer as best they can, being the trusted individual. Now, again,
Young parents today haven't seen what the devastation is
right.
of getting those childhood diseases. They need to talk to their parents and their grandparents. I remember children with polio. My little sister had polio. She had a mild case, fortunately, but for the rest of her life, periodically she was followed by a polio assessment, some kind of team, I don't know. And they would check, she would just be walking down campus and fall for no reason. Just her legs would give out. She was followed for years, for I think most of her life.
Well, as a youth, I do know people in my community with polio and I'm the effects of it, but correct, it hasn't been seen for so long and people don't. That's natural. That is natural. When you haven't seen it, it doesn't seem real, does it?
I guess not.
But the physicians do their best and they do address it when they come into the doctor's office, especially pediatricians. Flu vaccines are always offered to adults. They talk to them about shingles, and you can only encourage and talk best you can and be that trusted individual. But when you haven't had as much of a relationship because COVID disrupted your seeing them routinely, it does make a little bit of a gap. So.
It's amazing.
So we've also had some staffing updates that I'd like to share with you. You have our charts in front of you, which hopefully help you, see the functions and roles of our department. We've hired a new nurse, Lindsay Euchre in Alana's division of the lifespan. Belinda, who's on Zoom, has assumed the role of our WIC director. Jamie Thibodeau moved to Alabama. Yeah, Alabama. And her husband got a teaching coaching job down there, and so Jamie left. Belinda graciously and most helpfully agreed to lead WIC for the intern. And so we're looking at how we're structuring that division right now as we move forward. And then is Araceli sent their last meeting?
Yeah.
Araceli, don't even know her last name. Thank you. Has started in our well woman program. She's bilingual, and is also in Ashland, Alana's division, helping out there. Did I miss any other new hires?
We have the new staff person starting on Wednesday at WIC.
Yep.
Yep.
Another Jennifer, right?
Jennifer Straw.
Yep, Jennifer Straw. She'll be a nutritionist here at the WIC office. She's starting on Wednesday, the 23rd.
It'll be our fourth Jennifer on staff. I'll bring it.
Yeah.
We also have 3 Ashleys.
So other things that are kind of in motion right now that I just wanted to bring up. 2 Board of Health meetings ago, you approved a harm reduction vending machine grant. And the county executive asked for that to go to the Judicial and Public Safety Committee before it went to Personnel and Finance, which has delayed it about a month. It went to Personnel and Finance. We had discussion at Personnel and Finance. We had one supervisor that had a lot of questions about the public health vending machine, ultimately voted against it. All the other votes, the votes obviously from public health, and there wasn't a vote at Judicial and Public Safety, but there was one nay vote at Judicial and Public, or excuse me, at PNF, thank you. And it was slated to, it was put on the county board agenda. I was not able to make that meeting. Don was not able to make that meeting, the county executive. In the weeks leading up to that meeting, there was an article in the Honorable Herald where the sheriff and medical examiner really spoke out against the harm reduction vending machine grant. And it raised that has raised some questions and additional discussion. And since John or I really couldn't be there to address those issues, the intent was to give a presentation. John said, let's just wait a month on that one. And so we'll be bringing that back to the next county board meeting. But I guess I just wanted to take an opportunity to let you know that there's some significant resistance in opinions about harm reduction that may impact whether this moves forward or not at the county board level. So if there's questions about this that have come up in your mind since the last time we talked about it, if there are recommendations that you have for us about educating the board, certainly appreciate any insight you have or recommendations that you have in addressing this. We do want to make sure that you fully understand you know, why we applied for the grant, where the funds are coming from. And that you can also be an advocate for us, at the county board. You want those now? Sure.
Yeah, I had a couple questions that were raised to me, and then I couldn't even answer them because we weren't presented that here. So it seems like we're given some information and not another, and, I learned in our human services board that in some places the fentanyl test strips are illegal.
Or what?
The fentanyl test strips are illegal.
What's that, the xylitane,
So,
Xylazine.
xylitine.
test strips
Yeah.
for substances, whether it be xylitine or whether it be fentanyl. There was question related to the legality of these, whether this would be something that would be, drug paraphernalia. And Wisconsin had a law, and there's a number of states that have laws that say that test strips are drug paraphernalia. The Wisconsin legislature, I think it was 2 years ago.
Yeah, I heard it's not illegal either.
Yeah, that
Right.
basically, so from a state legislative standpoint, so our state legislators, I think, voted pretty strongly bipartisan wise, to make that legal, because they found that there was a significant health benefit to having people know what substances they were potentially using, or what substances were potentially in the community. Like the state of Iowa, I think they are illegal, so if we were on the cross, that would be a problem. But, or prohibition, but in this community, I don't think there's illegality related to those in Illinois, Wisconsin, and Michigan.
So there's not an active drug in the strips that they can.
No.
No.
Yeah.
And they are, and the other information we weren't given either. It just wasn't presented, okay, it wasn't well. Is these strips are to test the illegal drugs that these people are using.
Yes,
Yeah, so it's not for testing their PD before they get the market.
right.
No.
Yeah, you can use them, FD, but they're actually not FDA approved.
That's why I thought it was
Which is kind
odd.
of, which is kind of a goofy thing, even though they were originally made for that, because I've tried to get them in our own clinic, and they tell me they're not FDA approved. We can't use them. And I said, I can.
So
I
the
just won't
purpose
tell
of
you.
the fentanyl test strips is to detect the presence of fentanyl. So what we learned from our community is that people were using substances that they thought were methamphetamines or they thought was heroin, and it was essentially laced with the fentanyl, and that's what was killing people. And so we want, from a harm reduction standpoint, we want people to be able to make behavioral changes when they know that there's a greater risk of death in using that substance. And so that really is the purpose of the fentanyl test strips. And through our harm reduction program, we're collecting data on what kind of changes people are making as a result of utilizing these fentanyl test strips.
The other advantage of it is that, like, with, from working with Amanda, people do come back again and again, so we actually get a report on what's going on in the community as well. So people will say, we'll talk about, hey, are you testing your drug? Yeah. Are most of your drugs containing fentanyl? Yes. Which people who are using opiates, that's usually apparent, but there are people who are using cocaine, methamphetamine, marijuana, who are saying, hey, this is what I'm desiring to use, and are finding that that may not be what they're actually taking, so.
And then I would hope that these people that you're in contact with are also getting some kind of counseling, so they encourage the incorrect behavior.
So the purpose of our harm reduction program is to provide a safe, judgment-free zone for people to talk about what they're struggling with and what they need.
And you don't think it then some help to them?
I will be happy to finish my statement, which will get the answer to that question. But So we provide this safe judgment-free zone, which allows people to feel comfortable with us and open up to us. And when people feel comfortable and feel safe is when those windows of opportunity open up, that we can then work with them to get them treatment when they're ready to do that. And so as Dr. Smeltnick mentioned, our harm reduction program coordinator, Amanda, has all of these direct relationships with providers, you know, most often uses our human services department. So when people are in our office and it's that window of opportunity that they're ready for treatment, she has a direct line to one of the supervisors over there so they can get somebody an appointment as quickly as possible. We also utilize the app, the We Heart You app that has direct contact information or contact 24/7 to recovery coaches. So our goal is to meet people where they're at and help support them in their journey to treatment and recovery, whatever it is that is.
This information would have been really good to have been given. Maybe I might have been sleeping, so it might have been given 2 months ago.
It was.
And not in this form, because I don't recall talking about the harm reduction program itself in this manner.
So the other,
And then it definitely would have helped me discuss things with people that had questions, and I can bring that forward. So I think we can do a better job of presenting this in the committee.
But it's good that it came, get back to those people now.
Oh, but
And give them the information.
it'd be nice to have the information ahead of time and understand.
I mean, everything doesn't always come out at first blush, you know, we need this kind of
This
discussion. I
is,
think
this
that's
is a program that was going on, and it wasn't discussed in this manner, and that's what I'm saying, that we thought that wasn't presented to us. And on the outside, it makes me look bad, but how come you didn't talk about, how you didn't know this, not you didn't know that? And, so that means,
Well,
So-
and you
so-
shouldn't feel like you know everything because you came to the one meeting. I mean, you can
but
say,
I could have known this.
but you could say, I'll go back and discuss it further because either I didn't understand that part or that didn't come out in discussion. And it's gotta be an ongoing
I
discussion.
understand
You
that.
can't just talk about it once and be done.
I
so
understand, right?
the other thing that, so kind of our harm reduction is actually, or the harm reduction for the county is housed in this building. Right now, how the process works is that, people will go, to Amanda's office. And I've gone to Amanda's office because we actually, have started getting referrals from Amanda, specifically for Hep C, but also for treatment as well. For drugs and alcohol, and I mean, she has a ton of resources that are just in the office in general, so it's basically like going into the office, like, okay, like, I can pick this fire, that fire, this fire. About all basically the sort of locations that we're located. The other, I think, misconception that I've heard out in the community related to the vending machine piece is that this is a vending machine that you can just go up to, draw out some stuff, and be done with it. That's not the case. The purpose of the vending machine is to, that Amanda is only in the office a certain amount of hours. And outside of those hours, people may want access to things like Narcan, needles, or fentanyl test strips.
There
And I
won't be
think-
any needle.
And right now, there won't be any needles in the thing, but they may want access to these things. My understanding, and correct me if I'm wrong, is that you need a code in order to open the vending machine up. How you obtain that code is you need to talk to the harm reduction specialist about what the program is and how things work.
It does explain.
So you would get that type of thing. So I don't know if that, like, so that part was explained as far as you need to talk to somebody about, okay, what is this about? What resources do you need? And then, so that part was.
Yes. It's just not the whole program, and then that's wrong.
Well, so I think that it's important to also keep in mind that our public health vending machines, is what this data is calling them, are a piece of a program. It's a very specific grant that if accepted, is coming through the state with a specific criteria of what's going to be in there and what we can purchase through those grant dollars. So our decision is to run that through our harm reduction program, but they're not the same thing.
I'm sorry, that was, and so that's
They're not the same thing. We have a harm reduction program that includes our syringe service program here. And then we will also have these public health vending machines, which will have some of our harm reduction supplies like Narcan and fentanyl test strips in it. But it's also going to have things like hygiene kits, and I don't know, our preparedness person is recommending socks, you know, so it's a piece of our harm reduction program, not our harm reduction program in a vending machine.
good, well, that makes sense.
And I understand that, that's good. There's Cheryl, which I'm sure is the coroner, right?
No.
Is the one that the letter, I don't know if anyone's seen the letter that she sent out to all of us.
No.
She made a lot of that, I got copies here, but she sent it out to every one of our supervisors. And she made a lot of accusations, which kind of, you know, for me, it just was, it's kind of like a case like in the past. Where, you know, you vote on something a couple, 3 months before, and then all of a sudden, all this information comes out, so it makes you kind of think, well, that doesn't make you want to change, and that's what we're talking about. But when she made these statements here, like, holy cow, the coroner and the sheriff are against this completely. But some of the statements she made, and I'm not gonna read through, but she made a lot of stuff like, this has been going on for years here, and we have no transparency. That she's been talking to you guys for a long time and nobody's listened to her, and they kind of blow her off. So when you see that, it just makes you kind of think like, is that true or not? Because, you know, this is a good thing when we voted on a couple of months ago, we were great. But all of a sudden she brought points out that is dealing with us all the day with the deaths and issues like that. So for me, the first thing came to mind is that how did this all go through everyone else, but never really the coroner, and never had any info or ever talked about it? That's what I thought, you know, because, okay, they're dealing with all the time with deaths. Geez, I didn't know any of this stuff, so I learned a lot from that. Not that it changed my decision, but you pulled it last night or a couple weeks back. So it made you think, because I had no idea some of this, you know, and that's all I'm saying, because you know, like it was for me last time we do something, I want the grants are good to get them, to understand that part. But sometimes we don't get all the details from some other source, maybe we should, that's what I'm saying.
Yeah.
But if you read that, you'll see, he made a lot of statements that like kind of made me think, being part of the health work. Okay, I gotta look into this, it must be something I missed, you know, that's all I'm saying.
No, and I appreciate you sharing this. Since I haven't seen it, I would be more.
Right, I
address
didn't
that
think so.
now. But I can tell you, that we have met, many times with the coroner, and I've had a long ongoing relationship with the coroner related to this program, to the harm reduction program. We have regular communication with the overdose fatality review team. We share information about, potential pending, deaths that have occurred in our community, hearing about what the results of those are. And it's an important partnership, and we've met with Cheryl, in the harm reduction office. We've discussed this with her numerous times. We've also met with the sheriff. We've met with all law enforcement agencies within the county, related to this program. To try to make sure that, we update, their understanding of this. When we started the harm reduction program, over 6 years ago, it was out of what used to be called, our heroin task force. And there were multiple pillars in that task force, and harm reduction was one of those pillars. And so this is just, this program has been an evolution that's been going on for years. And, I think that, as time goes on and people assume new roles and new positions, it's like any of our other programs, they may not know or forget what the details of those are, or those programs, gradually evolve. And so we're happy to re-engage all of those partners, explain to them, what the current science is, what we've learned, and what we're hearing from people in our community, why we're doing, a certain programming. And really the harm reduction vending machine, the primary purpose of harm reduction vending machine, is to make fentanyl test strips and Narcan, and really Narcan available to the community because it saves lives. We know that the greater accessibility of Narcan within a community reduces the numbers of deaths in those communities, and there's a lot of evidence to support that. The public health vending machines are a way for us to do that, given that we don't have a lot of outlets for Narcan in our community. I mean, when it comes to the general public, we're pretty much it. So everybody has to actually come here to receive Narcan. Now, if we can have vending machines available, not only can persons that are using substances have access to that, but their family members, their friends, relatives. We say, hey, look, you know what? We really should have some Narcan at this location. We don't have it. Here's a way to access it. So this isn't about just serving, substance users. I mean, you can't administer Narcan yourself. It takes someone else. And so having the Narcan more available within the community, distributed out within the community, will ultimately help save lives and then hopefully help get people the recovery that need it. I don't know if you want to add anything else to that, but that is really the primary intent. It's about saving lives. And so from the coroner's perspective and the sheriff's perspective, we know it's difficult to go to these scenes where there's been an overdose death. And we know that it's difficult to see the materials present at the scene where someone used a substance. Whether that came from us or it came from someone else, I mean, they're gonna be present. Most overdoses are not intentional, they're accidental. And fentanyl is by far the most significant contributor to those basically accidental overdoses. So the program will help save lives. It will help hopefully get more people into recovery. And hopefully the coroner and the sheriff's department will see less deaths as a result. Granted, deaths are increasing. We don't know what they would be without preventative program, preventative programs like we have now in place and with the vending machines in place. Ultimately, they'll see less if we move these programs forward.
I've talked a lot with Cheryl, but I have not met with, Sheriff Marks. Lots. But
It's part of your outfit screen.
Yeah. Yeah, so Mike, this is just a director update about activity that's, currently occurring. If there's more information or if any board members have concerns that this is an open meeting violation, happy to address that. It's not our intent.
Mike
Collar just put into the chat that
Yeah,
he
that's
wants to
not-
make sure we're not violating.
That we're not taking any action on any items here, but we are discussing an item that wasn't specifically listed on the agenda. I mean, most of the things that I've discussed are on the agenda. They're just part of our general updates.
Thank you, sorry to interrupt. I just wanted to make sure you.
I didn't see that. Okay. And again, I just brought it up because we were talking about why.
No, I appreciate that. Distributing this information too. It's useful to have. I guess my question was, do you know what, Sheriff Motz's specific beat with the vending machine is? And it seems like he's very vocal. And it's an interesting piece of these are really two entities from the same county that are really significantly pounding on each other.
Yeah,
We're not really pounding on the sheriff, no, but the sheriff's just pounding on public health.
Yeah.
Is how I feel it is that it's an attack on this department and some of the work the person there, so.
I can't comment for the sheriff. I mean, when we've met, he's shared some opinion, it does. I guess what's resonated with me when I've heard from the sheriff is that he has a concern that our harm reduction program, is exacerbating the drug use issue in our community. That by offering harm reduction services, we're enabling behaviors, we're making the situation worse. And that, and we're just using the coroner and the sheriff for that we're complicit in the deaths that are occurring. And really our goal is to prevent them, not increase that. So I think there's, you know, law enforcement, in general hasn't been particularly supportive of these programs. I think there's a lot to learn, and information, hopefully more information we can share that will help them understand that, you know, our goal and the evidence is that these programs actually reduce deaths, not increase them.
Cause, I mean, it's interesting, like he runs the jail. So the county jail, and the county jail has been really, has some really good forward movement recently. We're a little slow on the uptake, but as far as utilizing medicines like Vivitrol, which is an opiate med that they've allowed that in, they've had some funding grants related to that, so I know that they're doing work with that. I know that Narcan is an important piece of discharge planning for that. They've allowed recovery coaching and stuff like that. So it's just like what the generalized data has shown is that communities that have more Narcan have reduction in overdose deaths. That's really is if we put this in a black and white thing and say, how do we get more Narcan into the community in a way that we can look at and pay attention to, and there's financial opportunity to do that with this type of thing. So I mean, I think that's really where things are at. And I mean, as far as further discussions, being a content expert in this area, and I'm happy to be tapped if needed on any further discussion if we want to say. Because I mean, I can ask questions that you can't as far as, hey, what's your goal here? And how do we work together with the goal? Because I don't think anybody's like, oh yeah, we want to see increase in the stuff. We want to see increase in use that isn't a goal at all. And then we know that the drug use area is just, hey, how do we come to that?
But maybe we could put on an agenda another time, because like some information we had here was taken off the board, so a lot of stuff is new. So if we bring it up at another time, we can talk about the questions we had, because that's the reason I had brought it. I didn't have anything until somebody presented it, so I don't just read the paper, so I think it's something we should talk about in the future, just so we understand what that's what Jeff was talking about, you know,
Yeah.
you want to make sure you do it, but sometimes you find out things you didn't know about, so is this the wrong place to ask a question?
No,
It's the right place.
I just
We
use
should
that
go.
statement that we are.
Yeah.
But we're in the meeting that we're discussing.
We're just like, no,
Our stuff, right?
I mean, that's my thought.
Given what's happened, yeah, I mean, I said, so, excuse me, hang on. I mean, just given what's happened with the issue and, you know, the responses from the medical examiner, the sheriff, questions that you had about this, the newspaper articles. My goal here was to make sure that you understood why it was pulled, and then to just readdress any questions, or concerns that you might have that, that we can answer and ultimately to help you support this when it gets to the county board level.
That's the whole thing, is to understand it so you can support it.
I think we did that.
I will also just add that I'm this, so the harm reduction programming, the vending machine, that all falls under the community health and prevention program where I'm the supervisor. If you have additional questions or want additional information, you are welcome to reach out to me directly. I'm happy to walk you through things. And in fact, if you have an interest in seeing a little bit more what that program looks like, I'm happy to kind of walk you through what that service looks like. You can see the office, you can see how we collect information, the kind of resources that we provide to people. So you can have that firsthand knowledge of what our program actually looks like, rather than kind of these alternate perspectives of things. So if you'd ever like to do that, we can schedule a time and I'll walk you through the whole thing, any of you.
Just look at, this is the best conversation we've had in the last 2 years that I've done before. This is what I thought. If you want to affect change, I mean, we live in a bubble, a little bit of a bubble. We're all, I don't want to say we're all on the same side, but we're all kind of working towards the same goal. We think alike. I'm not general, but out in the community, it's not that way. So I agree with Jeff. For every issue that, especially if it needs to be voted upon, we need to tear it apart. We need to know both sides. So we need to have this information on. Although it's uncomfortable, you don't want to think about what the opposing opinion might be. we need to be armed with that, especially the
Yeah.
elected officials, right? I mean, the community members, maybe not so much, but we're all having conversations. We need, the best way to engage the community is to know what the opposing position might be. So I think we're getting, I don't wanna say, we're getting the public health. We're able to defend why, but we need to be able to defend the argument. And we're not necessarily armed with that information, so I agree, we need to try to predict.
And it needs to be an ongoing conversation because it doesn't always, everything doesn't come up the first time. You know, you gotta keep discussing it.
Right. It's hard to
Yeah.
know what opposing opinions or questions people are gonna have, but we got to one.
And I think that's one of the reasons why at every Board of Health meeting, we try to bring some topic to inform and educate. So like last time we talked about, the DHS, the Department of Health Services 140. We talked about the Foundation of Public Health Services. So you have, we go through our deep dives, every division as explained. So it's a great opportunity for you guys to like ask questions and like Ashley said, ask us, come to us and ask us. If you get a question from the community, send us an email.
Sorry, got you off track there, Doug.
Thank you so much.
You brought it up. Another issue, and I'm not gonna try to send us down a rabbit hole here. Another issue that is coming up. Karen,
Good morning.
morning.
I just want to make sure you're all limiting your discussion to what's on the agenda. If anything out of it would be out of order.
Is there a specific concern that you'd like to relay or an area that you feel like you're treading or we shouldn't?
Yes, it seems like you've been talking a lot about harm reduction. And that's not on the agenda. You certainly can talk about it if it's on the agenda, but when it's not on the agenda, it would be out of order and you could be violating open meetings. And I know you don't want to do that. Nor does the board.
So we were discussing our harm reduction program. It's one of the part of the health programs, and giving an update on the current status of a resolution that the Board of Health voted on that has been moving towards the county board and is yet to be considered.
I would say you need to stop discussions on it because, again, I understand you talk about a director and staff update, but since there's this resolution and it's not referenced, it would be out of order. And we want to make sure that we're within the confines of Wisconsin statutory law. So just to avoid any issues, we need to immediately stop that discussion. We can talk about the 2023 year-to-date income statement.
So then the director and staff update.
Doesn't that give us free rein? Is this part of the
Yeah, we're
director update?
discussing what's happening in our department right now. given-
Well, no, you're actually talking about a resolution, and that's not referenced. So since you're getting into the specifics, and obviously we want to be transparent, I have no problem if you want to have another meeting and list the reference to the resolution in terms of, I assume, the vending machine piece. Yeah. So I have no problem with that, but since that's not on, and since it had been on at the county board meeting, it's not appropriate. You need to just not talk about that. But you can come back for another meeting.
Okay, so when somebody on the board specifically asks the question, then do we say to him, we can't talk about your question because it's not on the agenda?
Yeah,
Does this all
you
happen?
I'm sorry.
This all happened because someone specifically asked a question about,
Alright.
so
Yeah, so-
then what do we, so then what? Doug's supposed to say, sorry, we can't answer your question because it's not on the agenda?
No, but the fact, it's basically you've been having a discussion for 10 or 15 minutes. This is the problem. So you could certainly say, we looked at it and then say, we can get into it further at another meeting once it's actually posted.
Okay.
That's all I'm saying, because as you know, this is an open meeting and we've got Wisconsin statutory law that we have to go.
I'm gonna do that. I think he's brought it up and kind of pushed a little more, so I'm sorry about that.
No, that's.
But we thought being a director, he's making a report. Anything, because he really doesn't write down the list of things he's gonna talk about, so we talk about those individually, we just happen to land on a couple that were part of that.
I understand. I think, given what's happening, you can certainly have another meeting next week or whenever, you know, to talk about that.
That's great, thank you.
Because obviously there was a resolution that was pulled. So you're probably gonna wanna talk about that, and if you want to, then list it and then talk about it.
It's okay that it was brought up, as long as it was short in duration, quick answer, and if we need to have
Well,
further,
not
then it
if
would need to be brought up. Someone can ask a question.
Yes, but not if
Right.
the staff is bringing it up and saying, but obviously,
I
if
think
the
we-
question is posed,
Thank you.
Okay,
Okay.
thanks, sorry, yeah.
We are past that, I don't, but.
Yeah.
You know, I think, some clarity on that issue. I mean, this is a resolution that this board had already discussed in the past and had advanced. There's been activity related to that resolution. It hasn't yet been considered by the county board. And so I'm giving an update as to what the status of that resolution is that this board discussed and voted on, why it wasn't at the county board. And that certainly led to discussion about questions about the program itself and, you know, things that people maybe did or didn't know.
right?
We're
What
not
I,
voting on it.
I would say that since this was at the county board on Tuesday, and we can amend agendas in emergencies up to 2 hours before the meeting, but typically you can do it up to 24 hours before the meeting. It might have been a good idea to perhaps amend your agenda to put that on, just to, for future, because again, we want to stay within the parameters. Okay? All right. No,
I apologize,
no.
good discussion, but I apologize. Okay, thanks.
Hopefully I'm okay, risking another violation here. The next item, that I wanted to bring up was, and actually, from our corporation council, discussion that I've had and also an invitation from, a pending invitation from judicial and public safety, will be consideration or is, consideration of 11.08. And that is, that's our code of, our ordinances, or our health department code 11.08 is the specific code that currently exists that was created during the pandemic that which has restrictions on public health authority as it relates to general orders. So this issue is coming up. It's likely that I'll be speaking about it. I'm not sure what yet. I'll be answering questions primarily at judicial and public safety at an upcoming meeting. And Corp Council has asked some questions related to it. And so I just wanted to kind of give you an update of, you know, what 1108 is, you know, where it's kind of at and, you know, what types of, you know, activity could occur here. And so really 1108, when the pandemic started, the state came out with a general order, a safer at home order. That was challenged in court. That order was ultimately discontinued at a very sudden, moment in time, which really eliminated that state order. We, along with many other counties, were interested in having some time to help advise the community about what the next steps could be to help minimize spread of disease. At that point in time, Winnebago County and others put in an order to extend that order locally for, it was like 7 days, just to give us enough time to come out with some recommendations for our own community. At that time, the Attorney General's office and Wisconsin Counties Association, I believe council, said, you know what, we're not really sure that if you as a county haven't specifically listed state statute 252 in your specific local ordinance, that you actually have the authority to do that. And so based on those opinions, that order was rescinded within 24 hours. So it ultimately never really went into effect. And we started working on incorporating chapter 252 in our local health statute. You may recall that resulted in, a lot of discussion and some very large county board meetings. And we had hundreds of people present. And of course, this was, as the pandemic was really ramping up and we were seeing a lot of disease spread. At that point in time, it was Shiloh Ramos, the current county board chair and former chair of Board of Health, offered a compromise in adding chapter 252 to the local ordinances. And that was to make approvals of general orders subject to the county board. And that meant that the county board would then have to substantiate or support any general order made by the health department. If they did not support it, it would turn into a recommendation. That ultimately passed. And that's been what's been on the books now for the past few years. We never actually used it after that. No orders were ever issued. We gave general recommendations and guidance to the community. Nothing ever went to the board for any kind of approval because there was just no order made at that point. That remains in our code of ordinances. So if we feel that it's appropriate to issue a general order to the community, it would need to go to the county board for approval. Since then, this has been taken up by the state Supreme Court. There was a case involving Dayton County and an order that they put out. Ultimately, it favored Dayton County and basically said that yes, public health does have the authority to issue a general order. Counties can be more restrictive. Basically, that had no impact on us at that time because we added chapter 252 and we added a further restriction that the county board had to also support it. So I believe that there's, from what I've heard so far, we're already more restrictive than most communities. Since the case against Dane County essentially said, yes, public health, you have that authority. And I would have to look further, but I believe that's regardless of whether or not you're referencing specifically statute in your ordinance, because they're already state statutes. So there's going to be some activity related to this, or maybe some activity related to this. Certainly some discussion is already ongoing about changing 1108. And that, I'll have to, bring that to your attention when I know more about it. I believe the intent is to further restrict 1108 from where it is currently. So add additional restrictions on top of what's there to limit the ability of public health and limit so the ability of the board to pass a support for that. So more information to come. I just want you to know that I'm aware of it, wherever others, and we'll probably have some future discussion on it. Please let me know if you hear more about it. I'd be happy to discuss that with you. I really haven't spent much time on it because I've just had a few questions about it and an invitation to speak at digital public safety at a future meeting. I don't even know which meeting that's going to be yet. It may be the next.
I appreciate that you did that because first it was a board before us. Well, we don't know a lot about it. We heard about it second, third hand. So I think it's important that we discuss it again, not now. So we don't get in trouble.
Yeah.
No, yeah, we should, because that's a very interesting topic. And I heard a lot about it through campaign, and I've heard a lot about the people before. So I need to know more about it. So I think all of us would like to know more. So yes, I think you brought up another time would be great.
There may be activity in the future that may or may not come through the Board of Health. I mean, it could be a resolution that's introduced right at the county board, and that's where perhaps more discussion would occur. So that's really why I just wanted to bring it to your attention.
Thank you.
So, and happy, like I said, happy to answer more questions about what are public health orders, what are general orders, what are specific orders, you know, what does the statute currently allow, and all that. And with that, sorry, you guys, I can take a ton of time here. Please go ahead and give your updates.
And you're next. Yeah, you're up.
Okay, so for the sanitary program, just listed a couple new establishments. So Oshkosh had 4 new tourist rooming houses, which are the Airbnbs rentals. A new tattoo store, establishment, 1 nutrition club, and then there was a change of owner. Nina had 2 new food establishments and 2 changes of owners, and Fremont had a change of owner. Fox Crossing had a tourist rooming house. We're up to about 50 tourist rooming houses that we have licensed, for Airbnb rentals.
What's a nutrition club?
Yeah, where they drink, you know, they make smoothies, those with the protein and the aloe. And that's a club? Yeah.
Like a car wash, but it's a club.
Yeah.
Car wash, it's a club, no.
So special events, we've inspected 170 temporary food establishments since July 1st. That's when our fiscal year starts. And what's meant by temporary food? Temporary food would be like anything at EAA, we had 60 food establishments at EAA and 11 campgrounds that we inspected.
Okay.
And then Life Fest, we had 31 food establishments, County Fair, we had 26.
Okay,
And then just like 4th of July events, concerts, you know, farmers markets. So we've done 170, which is, we're back on schedule that we had before COVID. So things have been ramping up again. Our next big event would be the Monk Soccer Tournament. That's Labor Day weekend and Saturday and Sunday of Labor Day weekend. We'll probably have another 30 food stands there. And then lead, since last meeting, 4 houses have been completed. Lead hazards have been removed from the houses, and then 1 is currently in progress. So we made really good headway on that.
Want to thank you on the county board. You explained it a little bit better. Because the board was worried that was one big chunk going to supplies.
Oh, yes.
Levers. I appreciate that, made it clear, because that was a big discussion.
That was helpful, Bev.
Yeah, okay, yeah, that's good.
Good.
All right. Ashley with the Community Health and Prevention Division, just a few highlights on the things that we're working on in addition to the pieces we already discussed. So in the housing world, the focus is continuing on affordable housing, including both affordable rental housing and affordable homeownership. So those folks are working in coalition to plan a housing policy training for people experiencing housing issues and allies to just better understand policy processes and creating an educational presentation for the community groups to better understand affordable housing programs and the impact of not having affordable housing. In the substance use world, Breakwater, our Youth Substance Use Prevention Coalition, is really gonna begin focusing on the early initiation of substance use, and what they're really finding to be problematic is vaping and THC, and this beginning in middle schools. So they're just looking at prevention opportunities that they can work with the middle schools on. Yes.
Did you say they're vaping THC?
Yes.
Okay.
I've already talked about our harm reduction program, our COSA grant, that is the $1.3 million grant over 3 years from the BJA to support things like the solutions peer response team that I always talk about while we're here, and strengthen the OFR. It was meant to put a bereavement coordinator into the medical examiner's office, but instead we're going, she decided to go the route of bringing the victim crisis response team and expanding their services to Oshkosh. So we're helping support VCR and figuring out what it looks like to have them also provide services through law enforcement here in Oshkosh. They had already been providing services to the rest of the county. you all should have a copy of the overdose fatality review annual report. That was just printed and released. The OFR team has done a ton of things this year and put a lot of work into getting that report together and in a way for you all to see what they've been working on. That's a group of, what are we up to, nearly 47 people representing nearly 40 agencies. It's a pretty huge coalition. So very proud of the work coming out of the OFR. And then lastly, in our social connectedness / recovery support work that we do, that team is putting the final touches on a parents in recovery report. I think I shared with you all last time that we did listening sessions with parents in recovery to find out what social connection gaps are missing and how those folks can feel more supported in the community and be have greater success in their recovery journeys. And so there was a ton of amazing information that was learned through those listening sessions. We're compiling it into a report, putting the final touches on that, and then it'll go back to the participants that we have the listening sessions with for some feedback, and then we'll be sharing it out for some additional feedback before it's published.
Thank you. Thank you.
Thank you.
Belinda, I think you're up.
She needed to step into a visit.
Okay.
Okay.
So can I just read her updates real quick?
Melinda's?
Yeah.
Yeah, sure,
Yeah.
and I could probably, I might be able to.
Sure. So I think, Doug mentioned before that, Jamie Thibodeau, moved to Alabama. So, Belinda stepped in as board director. Already heard about Jennifer starting as an RD. The last bullet point is, the waivers will be ending. So.
Give a little background there that helps.
Yeah, okay.
So with, in WIC, you know, at any given point in time, we have over 2,000 people on caseload. And that means that, you know, we're seeing, you know, on a routine basis, you know, these 2,000 individuals, these are, you know, children up to age 5, pregnant women, breastfeeding mothers. And we provide them nutrition education. They receive vouchers for healthy foods. And then there's, you know, we try to link them with other services as we can to help improve their ability to have a successful birth and you know, successful childbearing. During the pandemic, and WIC is a federal program, during the pandemic, there was a waiver for seeing people in person so that they could still continue to receive benefit, and we would meet with them over the phone and attempt to get all of the information and education and do that over the phone. That is ending. And we are moving into, you know, some sort of a hybrid model. We're gonna kind of feel this as we go, but we're highly encouraging and asking for people to come back into the office. There's a benefit to interacting with people face to face. And we, you know, we can do a more efficient, you know, education. We can understand people better. We get to see the children. We conduct heights and weights and hematocrits or hemoglobin levels, blood lead tests. We can give them immunizations if they need them and they want them. Link them up with additional value-added services that we offer in the health department. And so we're transitioning back to that as of August 1. And so that'll be a change. Our no-show rate as a result of having the ability to meet with people over the phone dropped from roughly 20% to, I think, less than, you know, maybe 1%. Because it was just easy for people to engage with us and meet with us, you know, on phone or video, primarily phone, than it is to come in physically, you know, with their families to get benefits. So what we plan to do is apply our lessons learned from meeting with people virtually. But we also have this strong desire to see people come in. And so we'll be working through how does that best work? How do we keep people on caseload? Because they, you know, they're eligible for the benefit, they need that benefit. But sometimes the barriers of coming in from transportation or other issues, it's hard for them to overcome. And so we're able to, if we know that they've seen a physician, for instance, and we can get their heights and weights and the other information we need from that medical care provider, then we can do a phone visit with them, and they don't have to make another trip. And so hopefully we'll keep more people on caseload, and keep them engaged longer, and hopefully help improve those maternal child health outcomes that were before, as we move forward. That might have been more than you wanted to know.
Her last thing was just giving an update on, July participation counts. The count is 2,273, which I think is higher than,
Yeah, our enrollments went up during the pandemic. And because of the transportation barrier people have coming in. And, you know, our goal, of course, is to try to provide, especially, you know, those nutrition education services, for these young families, to as many as we can. And so, I mean, our benchmark would be how many families are eligible and how many are actually taking advantage of that benefit. And during the pandemic, we were able to see a larger fraction of those.
I have a quick question. Since people are leaving, people are being hired, I just want to know that currently anyone giving breastfeeding support has herself successfully nursed at least one child.
Yeah, that's a requirement.
Okay. Thank you.
I think I'm next. Doug shared already the foundational public health services assessment. So we'll be putting the final touches on that next week. It is due August 31st, so we are on the last flag race. Also he also gave an update on the community health assessment, so I'm not gonna go into that, only to say that Heidi, our public health planner, with assistant and input from staff from Ashley's group, has been working on this. So this effort was very deliberate in seeking out input from community members and community partners. So I think it's going to be a very robust assessment. The last thing update that I have is on our performance management system. We're almost at month 5 or 6 of having this performance management system purchased. Heidi, Sarah Jean, and I, with really Sarah Jean taking the lead, we've been trained. We are in training to become sort of those super administrators or super users of the system. But in the last 2 or 3 months, we've met with different divisions and different staff to identify who will be that data management, performance management champion for each division. For example, we have Susan Sattler in the CD division, who's already has an account in the performance management system. So we're chugging away. It's going to be a long process, but our hope is to have a robust performance management system for the department that will showcase sort of key performance and leading indicators for each division. So more on that later. That's all I have. Jackie?
And next up, Doug talked about the uptick in COVID, not a surge, but an uptick. We're seeing that in the wastewater and hospitalization. I did do a short talk about the fall vaccines, because some of these are new. We talked about the influenza, which we encourage people to do that in October. COVID-19, we know we're getting a new and updated vaccine this fall, don't know the exact date yet. It's going to the XBB variant, which is currently the one that's circulating a lot. It'll align a little bit better with that. The dosing schedule will be slightly updated, even if you've never received a dose. We know that that's likely, hasn't been approved yet, but likely to be a single dose and done, even if you've never had the vaccine again prior. But they're waiting finalization on that, and we'll know more as we get closer to the date. RSV, the other one that Doug was talking about, that new one, that is a more durable vaccine. You get it once, it lasts a couple of years. We're hoping it'll look better. Are encouraged for people 60 and older. They're currently looking at ones for people that are pregnant. Women would be getting that at 24 to 36 weeks, although that has not been approved yet, because that does pass on to the baby and will give them protection up to about 6 months, And that will decrease hospitalizations and doctor visits, because that is very common in infants. But otherwise, they do have antibodies, not a vaccine, and that is available currently, and they're recommending that for all infants under 8 months old going into their first season. And even for those that are high risk, if they have some other health issues, for those that are 8 to 19 months old. Now, that's the stuff that I think that community members may be asking me about, but communicable disease, not a people don't see this as much, but majority of our time, there's 5 nurses in the division, that includes myself, is spent with follow-up on TB, latent TB infection. We currently have 25 open cases. Many times, you get a case and you realize somebody got a test and they really weren't high risk, and you just recommend they follow up, we test it for about 6 months, and it's maybe a false positive. Those aren't the cases we're talking about. We're actually following up and trying to check on people. That is quite a bit of time that we spend on that, majority of our time.
You mentioned flu shots, you recommended October.
Mhm.
I got talked into getting my flu shot in August.
It's okay. Sometimes, it's more of a.
Because I said to the pharmacist, I said, now, farther out, is this gonna fall off and I'm gonna be in trouble in the spring? No, you'll be fine. I'm fine.
Yeah,
Okay.
it's encouraged because, it's partly an opportunity. Yeah, are you likely to go back? No, but if you're there, they're happy to, and it's good to get it.
Okay.
A healthy immune system will impart longer lasting protection. For those with weakened immune systems, we would recommend a later vaccination, ideally still before, flu really ramps up. For most people, getting it, by October usually imparts immunity, which takes a couple weeks to develop, through the flu season. And we see that we have a good vaccine match. And we believe we will this year. When we monitor in the Southern Hemisphere when flu activity is occurring to get a sense of what we think is coming this way, and the vaccine is a good match. And when we have seasons of good matches, we reduce hospitalizations by roughly half of what we have without that.
We monitor what goes on in the Southern Hemisphere. What do they do? How do they monitor?
They look at us.
It's always evolving, so they're looking at the strains that were in the Northern Hemisphere their season prior, and they're adjusting theirs.
Okay.
All right, we'll move on to the Healthy Lifespan Division. We're doing great. We've got full staff capacity and everybody's doing well with their training and orientation. It's helped us kind of expand more into some partnerships. So we've been getting out a lot and working on possibly moving our parent resource hours into the community. We're working with a new expansion at the Boys and Girls Club, the community center, to try to have some on-site days where we can provide services right there for the families. Also visited with the Tiny Homes Village, and Father Cars has contacted us to maybe do some services out there. So we're very excited. The Well Woman Program bilingual coordinator, she's from the Menasha area, has been around for a long time. So she's excited to bring her experience and cultural background into that role. She'll be at Latino Fest coming up in Appleton, and we're excited that that capacity of Nina has really helped us with her interpretation, being available every day there. Our home visiting is picking up. We're getting those referrals from ADRC, Human Services, so both on the young moms and babies breastfeeding support, and those we have seen increase recently, and we're glad that we can manage them. Otherwise, we will be out and about a lot in September. We have about 9 different festivals or health fairs or fall prevention events that we'll be going to explain about our classes, our visiting programs, and really help people navigate some of the resources they might not know about in our community. So we're doing good. Any questions?
Excellent. I think that's all we have for updates.
Okay, well, then we're on to income, right? Yep, statement and budget plan.
Yep, you have, including your packets here, printed out, income statement, just to give you an opportunity to see where we're at this year with our budget. Through July, we're at roughly 58% of our budget year. So we would expect expenses in general to be at 58% or less. Revenues are, and we're at 51% right now. And actually I ran this August 14th, so we're well below the 58% on what we had budgeted for expenses. Our revenues are at 42%. Typically those lag a couple months because much of our revenue is grant related. And it usually is a couple of months before we realize those in our budget. So even in terms of, I mean, even if we close the year out right now, I mean, we budget for an $800,000 deficit because we're using reserve to balance budget. And so you can see, we're at 956,000. And I know we have, a couple months of revenues to be realized yet. So budget's in a good place. Just as a reminder, our budget, we've typically been under budget. We've always been under budget, as long as I've been here. And a lot of our revenues are generated from expenditures. So they're reimbursement type of contracts and grants. So if we don't spend the money, we don't receive the money. The levy is becoming a smaller and smaller portion of our total budget. And that'll kind of lead me into perhaps just a quick update on the budget for next year. Are there any questions on the income statement at all? Anything that jumped out?
Just in general, do you have a year-to-date budget? Is there a month-to-month budget?
Is there a month-to-month budget? No. I mean, we look monthly, we run an income statement and review it. But I don't think we predict expenditures by month such that we know that in, May, this is where we're expecting to be. If that's what you mean.
That's what I'm asking.
Yeah, no, we don't do that.
I think one question, what was the big jump in miscellaneous revenue?
It's only a few $100s if you look at it, because we don't budget much there, so.
I know, it's only $200, but you don't budget much, but you got significant amount over.
Where we had the extra $300.
We did have a donation from our Wellness Plus classes, like not asked for, they gave it to us, so
Oh.
that was like just a.
That kind of thing, okay.
Yeah, go back to supplies for the classes.
Okay.
Thanks. Yeah, those are very tough donations are very tough to predict. We don't count on them, and when we get them, so it makes like a big variance.
One question I had in there, probably go off, is any of the grants that you get, you ever have a chance for a grant is out there and the paper wasn't right, or we have to reapply, or doesn't get paid on time? Has that ever happened?
We know that, I mean, we typically have a larger lag than we would like in receiving reimbursements for grants. I think that's the biggest challenge that we have in terms of a funding source disappearing or money being taken back. That is really uncommon. And we've had a couple of situations where, we've heard, hey, our federal award, or what we anticipated on having, is less than we anticipated. Then we'll have a discussion about what have you not spent yet, and can you, is there a way for you to reduce the expenditures that you planned on, during this grant cycle? And I mean, that's happened a couple times maybe in 10 years, but
I was curious.
we've never been shorted.
There's always certain things you have to do to get that grant.
Yep.
And then I always wondered if you go down the road and something showed up that they didn't okay, and now the grant money sits there and you don't get your money or stuff like
There
that.
are regular audits that occur. I mean, the county does an audit. So there our single audit, which reviews all of our grants and reviews our expenditures, and we hear from the auditors, like, they want more detail. They'll ask us for, okay, in this month, give us everything that you request a reimbursement for. and show us what those expenses were. I mean, so there's tests on that that occur regularly. We've never had an issue where we've had to have money taken back.
And every grant comes with a very specific scope of work, and it delineates very specifically what is an allowable expense, what is not an allowable expense. And each person who is in charge of a grant, so grant manager, and Bev, our accounting associate, are very, very careful that we're always questioning, is that an allowable? So, oh, let's pull up that grant again. That's, so we're very, very careful. Okay.
And then, just wanted to just talk a little bit about, you already know that we're in the planning stages for 2024 for budget. The challenges that we're gonna have, this year in general are a significantly higher amount that's being spent in labor. When we looked at our 2023 budget and budgeted for labor, and if we compare that to what we're budgeting for 2024, our labor increases with the same number of positions in place, we're like $470,000 higher. And so we're trying to absorb that large increase in, so it's roughly 11% increases in labor. We're trying to absorb that the best we can within our budget moving into next year. We know that, we don't have that much more money as a county. Hopefully some things like shared revenue will help. But, we're all looking to, save where we can. We really didn't have a budget target this year. And so we're just doing our best to try to find where savings are. We've submitted a labor budget that includes a few changes that I'll talk to you about. And then we've submitted the rest of our budget, our best guess on that, and we still have to meet with the county executive yet, so nothing is final in any of this. And you'll after we meet with the county executive, he meets with all the departments, you'll get a copy of that. The changes that we're asking for this year in our labor table, which are probably the most significant changes, and most of them are relatively minor, but one is in your org chart that you have in front of you, we have public health aides in WIC and in administration. We also have accounting associates. We're proposing that we just call them all accounting associates moving forward.
Administrative. Yeah.
I'm sorry. Thank you.
You're welcome.
Administrative assistants moving forward. That'll help with recruitment. It'll also just put them all, it'll just decrease the number of classifications that we have at present. And it does give those public health aides a little bump up, and it helps us with retention. So that's what we propose. That it's a fairly minor cost to us to move. Another change that we're looking for is to, because of the needs that we have in managing all of these grants and revenue streams, we're asking for a reclassification of our accounting associate into an accounting position that will that better manages the skills that we're looking for right now, and would also help us in the future with recruiting an appropriately classified person. The finance department provides support for us, but we really need to have a full-time person within the department that understands, our dozens of revenue sources that helps our staff make sure that they're expending appropriately. It's a double check for us that way. And Bev's doing a fantastic job. We've submitted the most detailed budget we probably have ever submitted for consideration. Because, Bev has really been able to help us, and that'll help us into next year as well. So really looking forward to hopefully upgrading that accounting associate position to an accountant position. You may recollect that we've had, in the past 4 years, I think we've had 4 accounting associates, and that hurts tremendously in terms of our ability to really see where the numbers are at, what we're doing, take advantage of dollars that are remaining. and just, and make sure that we're doing all the reporting that we need to do, so that we are successful when there's an audit. And then the last thing is a deputy director position. In the last budget, the county executive removed our policy and equity coordinator position, and proposed adding on a deputy director position that was not a part of the budget. It was an amendment. In discussions with the county executive this past year, you'd really like to see a deputy director position within the department. And so I proposed adding that position. There's still some consideration as to whether or not that is gonna take the place of one of our 6 division supervisors or be an additional position. We've actually lost another position, so we'd still end up with a net, FTE count that's the same, with a deputy director position. I am proposing that we have that separate as additional capacity as opposed to reclassifying a current supervisor, so that we actually have that additional capacity and it's not, the supervisor duties plus something else, and for a one pay grade increase. There's definitely a lot that, that deputy director position could add in capacity for us in terms of exploring new opportunities, implementing a strategic plan across the department, really monitoring how well we're doing on that. Implementing our workforce development plan. There's a lot that I think that person can do to help us if they're not completely burdened with what the supervisor is already doing. So that'll be my proposal, going in with the county executive based on his recommendations. And let me see if there was other, and as Belinda has now taken the WIC director position, we'll be looking to utilize that staff position that she was a nurse, split, still is a nurse, split between Atlantis division and WIC. What we're looking to do is to use that position authority on the TO or change that to a community health worker. Someone, we're trying to get more people in the community, from the communities that we serve, just do a better job connecting with them. And that would actually save some money from a nurse position salary and help us do a little more direct community engagement, meeting people in the community where they're at. It also helps bring back more information for us about, how we could be more successful in our programming. The rest, those are really the major changes that we're considering. Again, I'll meet with the county executive, or we'll meet with the county executive sometime in the next couple of weeks, most likely, and hammer that out. The biggest thing is, where do we find the savings to balance the county budget now that we've increased wages, which is fantastic for recruitment, retainment, and was long overdue. But we got to figure out how to pay for it yet. So
That's one of my questions I have. The answer, that some of that 400,000 must have been the increase in employees.
Well, that and, any step increase. So what I'm doing is I'm comparing what we expected to pay this year with what we're expecting to pay next year. There's 4% there that goes towards, a regular adjustment, an evaluation, it was gonna be a little different this year. But liken it to a step increase, I'm not used to words here. We're great, since the consultant did the pay study that she recommended that we consider 2 separate increases. One is just an adjustment in the pay scale to keep up. And the second would be what had been a pay per performance increase, which will be similar. It'll be based on an evaluation, more of a pass fail this year, but that's 4%. And so if I say there's 11%, 4% of that is what we would expect without the pay adjustments. The other roughly 7% is likely due to the pay study and bringing people up in the pay scale to where they really should be based on their experience. And so that's that 7% that we're, trying to absorb. And remember, most of our budget is, is grant funded, so, we're charging, well, essentially are charging the grants more, for labor, and still trying to support those levy positions, because it's the levy positions that, our tree trunk, right, that supports us being able to get all these grants and bring these other staff on. Without that core levy support, we wouldn't be able to, apply for and maintain and manage and execute the number of grants that we do. And that has, resulted in a lot of savings, off of levy, these past few years. Because essentially we've been able to use grants to pay for work that our regular staff, do, and that has increased our reserve. And so for next year, we're also proposing, another $800,000 be applied to lower, our levy costs, to the county. And so our total levy is, I think, roughly 2.6 million. We'll bring that down about 1.8 million by using $800,000 from our reserve. Our reserve right now, I believe, is around 2.4 million. So we're using effectively almost, we're offering up almost a third of that, and it's higher than we need it to be. So it's an okay time to do it. And so there may be some adjustments in that. So, as we meet with, HR administration, county executive, we'll figure out how to best move forward and, save some money.
How many employees are we short now?
In terms of vacant positions, I think we have one right now. Yeah, which is pretty good. And we do budget, some wage turnover savings as well. We assume, when you have, about 50 staff, vacancies are, a common, and so we expect that during the year that we have, at least one FTE that's vacant, and then so that we under budget on labor, that if we budget for everybody, we'll, it's more than we need, because we'll have vacancies.
Last question I had was, are your deputy director talked about, I know there's rumor about some reshuffling committees or boards and that, so I don't know if that would affect it or not, or I haven't seen exactly.
No, that's just, as I mentioned earlier, so there is, the county board has some committees or task forces, or they were looking at committee structure. We're waiting to hear what the outcome of that is. For citizen members, you may not heard much about this yet. The county board has put together a couple of committees to take a look at the overall committee structure within the county. And they're proposing to combine some committees together. So for instance, public health and human services, and Parkview and veteran would be a consideration of consolidating those into a single committee where we'd have a single meeting for all four of those departments. And there's other efficiencies that are being looked at by the county board in moving forward. Just not sure how that's gonna go.
It's a pretty drastic slide, because currently there are, supervisors are currently serving in 70 committees, doing work in 70 different places. There's 70 of us, there's 36, because you have more than one thing. So there's 36 county board members, but 70 human people are in various committees. They're talking about eliminating 29, which would then give us 41 people doing the work of 70. It seems drastic to me. It seems unworkable to me, but I haven't heard the whole task force.
I appreciate your conversation. I don't want to get in trouble Rob on something we shouldn't be talking about. But that's another topic, and that I think, we were saying at the end here that it's great to have conversation. The more conversation you have, the more knowledge we all have, or whatever. So I appreciate everyone. My first time doing as a chairman here, but I appreciate all the information you guys gave it. But I think we should have a meeting or two somewhere in there that we maybe take an extra hour that we add to the presentation or afterwards, that we discuss stuff. Because that's the only way all of us kind of have more knowledge, so we're not intelligent on the other end when we do this. And today I appreciate what you guys did. I thought that was great. And so, and I didn't mean to get everybody in trouble, whatever.
It's just ironic to me that this is like the first meeting in years where we haven't planned a specific educational component for you as a part of the meeting. And it's the one meeting where.
I did, yeah, okay. No, it was appreciated, so it was good.
You mentioned getting funding, Doug, from, grants. Are these private grants? Are these grants from the state or the federal government? What are these grants?
Yep, so most funding is passed through from the state, and some of that's state dollars and some of that is federal dollars. We also have some direct federal grants, and then we have grants from other either federal organizations or state organizations or local organizations. I mean, we have probably a couple of dozen funding sources. And so it is a wide variety. Mostly monies that pass through the state. So, I mean, and just as a reminder, we rely so heavily on those dollars. You know, Wisconsin is still ranked at the bottom of all 50 states in terms of their investments, per capita in public health. We're like 48, 49, or 50, depending on what year it is. We, as a state, invest very little money compared to others. So, and so we rely on a lot of that federal pass through. And, you know, locally, many of our programs are not supported with any local dollars at all. It's just grant dollars. And if we don't have those grant dollars, then those programs just go away. So,
And then are there any programs or, activities that you do that need to be reimbursed? And I'm asking this in Board of Health, Human Services, we might provide some service that should be reimbursed, in, say, mid-2021. Then you do the budget for, at the end of the year for 2022, and that money hasn't been reimbursed. So you're asking for it, and sometime in mid-2023, it finally gets reimbursed, and suddenly you got this influx of money that you didn't have, but you knew was coming sometime, and you can't even say, well, like, what percentage might we see of this being, you don't ask, they say, don't ask. It's too complicated, we're not telling you, you'll get it when you get it, and you don't know what percentage is gonna be reimbursed. So do you have that kind of thing where you provide a service in 1 year, the whole next budget year gets gone, then you're midway through the third budget year before you probably see the reimbursement?
we used to, the Wisconsin Medicaid Cost Recovery Program, which is maybe what's being referred to by Human Services, tries to help make counties whole for dollars they spend on MA related services that are reimbursed below what the actual cost to provide, you know, a usual or a customary rate. And so we did have that. It was a fairly minor amount, and anywhere from $5,000 to $20,000 was really what we were recovering in that program. But yeah, it could be 2 years before we saw that. We're no longer providing the services that are eligible, or I should say, we're no longer billing MA for the services in which we received that reimbursement previously. And so we don't really have an impact now.
Okay.
Another question?
I had one more consideration on the budget that more of a just, want to hear from you, your thoughts are. We have budgeted a few $100,000 in our project and temporary labor account. Those are from grant source, reimbursable grant sources. Public health infrastructure funding, there are some remaining COVID funding that we have the authority to expend through 2024. And so we're looking internally at ways in which we can utilize that few $100,000 in terms of additional capacity as opposed to just reimbursing an existing staff person and putting more money in reserve. And we can do a better job in our community if we actually provide additional services on top of what we are while we have these limited funds than if we just put the money in reserve. So we're looking at a number of things to help increase our capacity moving forward. Things like chronic disease prevention. We do very little work right now, in prevention of diabetes and heart disease. we don't do anything in terms of, our arthritis or aging, Alzheimer's, these diseases that really develop based on either conditions in the community or behaviors or a combination of both over decades of time. There is likely to be some chronic disease prevention funding coming from the feds. That's one area that we're looking at, perhaps bringing some capacity on so we can be ready for and apply for these grants, bring those funds into our county. But I'm interested, and so that's just an example, but I'm interested in where you might like to see, or if you have any thoughts or areas that you'd like us to have more effort, through the end of next year, and that we can, examine and consider for that, because we have not made final decisions on that at all. We're in a position that we're not usually in, with some funding that's available, that we were spending a lot of money on the pandemic response. We're not spending so much on medical anymore, and so we do have some dollars left that we can use to respond, yet to the pandemic and to help with the infrastructure needs that public health has had, as it's, the funding for public health has gone down quite a bit, and so we have some additional dollars right now to help out.
If we look at all of, I talked a little bit about like, Hep C treatment, Hep C prevention, and that Hep C is obviously a portable illness, so we're already getting portable Hep C. And we've been, with the increase, with the kind of the opiate use issues and injection drug use, Hep C increases, especially in younger folks, have increased pretty dramatically. Throughout the community, or throughout the state and nation, but also there are this relationship with the benefit as well. I don't know if that's an area that we look at all, like we want to delve into that.
Yeah, Hep C is more on our radar, because of harm reduction. We have received reports in the past. Hep C is also a treatable disease now, where in the past, there wasn't treatment for it, although it's still quite expensive to treat. Jackie, any additional thoughts about it? But we can look at.
But yeah, I would be happy to support some of that stuff. I know that Laura's actually bringing in a second infectious disease specialist who that's been her focus in some of the training of lucky. So I think we have some opportunity to present the thing. What we've found is that people are aware of testing for hepatitis C, but that there's a lot of folks who are not getting into treatment. The treatments are highly effective, so if we can get people in treatment, the likelihood of curative treatment is high. Just that people are just not getting into treatment because of the so.
Sure, we can definitely follow up on that. I think it's a matter of, is the funding, are people able to access treatment? If we can get them into treatment, how is it paid for?
And right now, it's interesting. So like most insurers are doing a pretty decent job with covering some of the newer, very highly effective treatments. Medicaid has done a lot of work in the last 3 or 4 years of reducing the burden for prior authorization. So that was one of my big concerns, and why I actually delayed getting into being a treating provider was the administrative burden of trying to go through doing the bills and then piece of paper to get this covered, and they've done a very nice job of reducing that. So I think I've the last year's like they do people are in our clinic, I believe.
It hasn't been that long that Hep C has actually been treatable. There was never a cure for Hep C until this past decade.
And it's kind of interesting. So the Hep C, what we had been seeing 10, 15 years ago was that Hep C was really a disease of sort of the baby boomer population. And it was mainly related to that there was significant blood supply issues in the sixties and seventies, so we had this huge amount of people who were in that age group that had had Hep C for a number of years and didn't know it. And the, CDC, put out some significant recommendations to say, let's get people tested. We really are recommending strong testing for folks, because we know if we can test them, that will reduce the downstream issues related to Hep C, which would be liver cancer and cirrhosis and sort of transplantation. So in like 2010, Hep C was like the number of leading cause of liver transplantation. Actually, with the testing and then treatment of this, kind of this, older, a little bit older cohort, that's actually flipped, whereas there is not as much liver transplantation related to hepatitis C, so it actually did something related to that. But with the surge of injection drug use, unfortunately, the residues of hepatitis C have kind of shifted now to a younger group, so.
Something else again, right? Anything else? And we're on to number 6, which is our next meeting, which is October 20th. Did it work okay with everybody?
I'll let you know if there's, I mean, I'm not anticipating any voting items for next month, and I'll let you know if there's something urgent that comes up or we need to convene. But without that right now, we could just plan for October if that works for you.
Yeah, and then again, just a comment, sometime if we could put it, I know it's a little longer, but you put that extra 40-45 minutes on the discussion on one of the topics that we talked about, that we can expand on to get more knowledge on and make more information for us, be legal,
What was that date again, October 1?
October 20th.
Okay.
Is that preferred over meeting every month for a shorter period of time?
You're worth to reconsider. I know the board had this discussion several months back and decided to meet every other month for longer, as opposed to every month for a little shorter time.
So right now our meetings are 2 hours long.
2.5, maybe 2.5. I think we're budgeting 7:30 to 10.
Gotcha.
And I know you're keeping it away from your working today for a while, but I think in the future, it's always good for that extra discussion. So your presentation is always great, but maybe at one meeting, not a presentation, more like a discussion on 2 or 3 topics, would be the same time for 2 hours or so. But that's just an idea. Maybe when Rachel comes back, being the chairman, she can decide if she wants to do that. But no,
I would be supportive of that, and I would just figure out how we agenda, but that's an agenda.
Oh,
yes.
that's the thing, talk to corp counsel, and I still don't think we did anything wrong.
I don't think we did anything wrong either, but I'm gonna ask for more clarification just to be sure, and I'll pass that information on.
But it's nice to talk about stuff and ask questions, and get more information out there, and everybody's here to kind of answer it, so. And we get deeper into stuff like we did today. But again, thank you. Okay. Well, then next, adjourn. You want to adjourn?
Adjourn. That's adjourn.
All right, second, all in favor? Aye. Aye, okay, here we go. Thank you, guys.
Who
Thank you.
Who motioned and who seconded?
I seconded it. Did I know? Maybe I moved it.
And
We have to-
we're shutting off.
That was real fast.
Thank you.
Sorry.
That's okay.